I'm Joe Graydon.
And I'm Terry Graydon. Welcome to this podcast of the People's Pharmacy.
You can find previous podcasts and more information on a range of health topics at peoplespharmacy.com. Millions of people have thyroid problems, but many of them are unaware that their symptoms are due to hypothyroidism. This is the People's Pharmacy with Terry and Joe Graydon.
The synthetic thyroid hormone levothyroxine is the most prescribed drug in America. At last count, nearly 20 million Americans filled prescriptions for Synthroid or one of its generic counterparts. How well does this treatment work for underactive thyroids? Some people say they feel better if they get an additional thyroid hormone called T3 as well. Why is this so controversial?
Some people suffer from an overactive thyroid gland. What are the symptoms and how is this condition treated?
Coming up on the People's Pharmacy, find out how to treat common thyroid problems.
First, the news.
In the People's Pharmacy health headlines, Americans spend even more time sitting now than they did at the start of the 21st century. That's the conclusion from a study of more than 51,000 individuals, including children, teens, and adults of various ages. The research was published in JAMA, and it shows that television viewing time of approximately 2 hours a day across various ages hasn't changed much, but people are using computers much more during their leisure time. As a result, adolescents and adults both spend more time during their day sitting in front of a screen. People over 65 in particular have increased their leisure time computer use. Sitting for many hours a day is bad for health. Some analysts have taken to calling sitting the new smoking. While that's undoubtedly an exaggeration, too much sitting appears to increase the risks of developing hypertension, high blood sugar, elevated cholesterol, and premature death. Experts say standing is only a little bit better. What may help more is getting up and walking around every hour or half hour. Even better is incorporating regular moderate to vigorous physical activity into the day. A study published in the Journal of the American College of Cardiology shows that physically active people are less susceptible to the negative effects of sitting.
How do you start your day? Do you eat a wholesome breakfast or do you grab a cup of coffee and dash out the door? New research based on 6,550 American adults found that breakfast eaters are less likely to die prematurely from cardiovascular disease. This epidemiological study followed participants in the National Health and Nutrition Examination Survey for 17 to 23 years. 59% of the volunteers always ate breakfast, while 5% never did so. 11% rarely consumed breakfast, and 25% breakfasted occasionally. People who skipped breakfast were 87% more likely to die during the study. These data tell us nothing about the quality of the food people had for breakfast. While it does not establish cause and effect, the link is strong enough to suggest that breakfast should be part of a healthy lifestyle.
Could a Mediterranean diet help you maintain a healthy weight? A fascinating study in non-human primates suggests that it might. The researchers divided 38 monkeys into two groups that were offered Western-style or Mediterranean-type diets formulated to mimic human eating patterns. Over the course of 38 months, roughly equivalent to 9 human years, the monkeys on the Western diet ate more than they needed and gained weight. Those given a Mediterranean diet ate less, sometimes leaving food when they finished eating. They had lower body weight and less body fat, as well as lower levels of triglycerides circulating in their blood. Monkeys on the Mediterranean diet were also much less likely to develop non-alcoholic fatty liver disease, an increasingly prevalent problem among humans in the U.S.
Chronic kidney disease has been increasing in the U.S. and now affects 14% of adults. One possible way to reduce the chance of developing this serious condition is to follow a plant-based diet. That's the conclusion of a new study of 14,686 middle-aged adults over more than 2 decades. The people who followed a healthy plant-based diet were 14% less likely to be diagnosed with chronic kidney disease compared to those who ate more meat. The researchers noted that the benefits of concentrating on vegetables, fruits, nuts, whole grains, and legumes were especially clear for people of normal weight. Among those who had kidney disease already, those who followed a healthy plant-based diet maintained their kidney function longer.
Acupuncture has once again been shown to help ease symptoms of menopause. The most recent study, published in BMJ Open, randomized 70 women in Denmark to receive either 5 15-minute acupuncture sessions weekly over 6 weeks or to go on a 6-week waiting list for acupuncture. Those who received the acupuncture from trained family physicians reported fewer hot flashes and night sweats, as well as less trouble sleeping. They also had fewer emotional ups and downs and were happier with their skin and hair. This is not the first study to show that acupuncture can be helpful during menopause. And that's the health news from the People's Pharmacy this week.
Welcome to the People's Pharmacy. I'm Joe Graydon.
And I'm Terry Graydon. How's your thyroid working? Chances are you've pretty much taken this crucial gland for granted. But thyroid problems are extremely common. An estimated 20 million Americans have thyroid disease, and many are unaware of their condition.
To find out more about common thyroid problems, we turn to Dr. David Cooper. He's director of the Thyroid Clinic, and he's professor of medicine and radiology in the Division of Endocrinology, Diabetes, and Metabolism at the Johns Hopkins University School of Medicine.
Welcome to the People's Pharmacy, Dr. David Cooper.
Yes, happy to be here.
Dr. Cooper, the role of the thyroid gland, it affects every cell in the body, but people don't always understand what that means. So could you just give us a quick sense of how important the thyroid is to our well-being?
Sure. The thyroid is a gland, and a gland is a structure in the body that secretes chemicals, which we call hormones. And the thyroid is part of the endocrine system, which is the system in the body composed of different glands. For example, the thyroid is a gland. The ovaries are glands. The testes are glands. The pancreas that makes insulin is a gland. And so glands are structures that secrete chemicals that then have actions at different parts of the body, in fact, in most parts of the body. So the thyroid is one of the glands you have in your body, and it secretes hormones into your bloodstream that then go on to affect the function of most of the other organs in your body. And the thyroid hormones, they're called thyroxine, which we abbreviate T4 because it has 4 iodine atoms attached to it, or T3 because it has 3 iodine atoms, then is secreted by the thyroid, travels in the bloodstream, and as I said, is taken up by virtually every part of the body. And what does thyroid hormone do? It regulates what you might call your metabolism, which is just a fancy word for how fast things in the body function. So, for example, how fast your heart beats, how fast you think, how fast your bowels move, how fast your muscles contract, those sorts of things. And of course, we all know that thyroid hormone is important for caloric expenditure, and so if there's too much thyroid hormone, you might lose weight, or if there's too little, you might gain weight, that sort of thing.
There's also a psychological component because when people's thyroid is out of whack, when there's too much circulating in the body, people often complain of, feeling hyper, like they had 5 cups of coffee all at once. And when their thyroid is too low, they sometimes complain of feeling down in the dumps, depressed.
That's absolutely correct. So thyroid hormone also affects the brain, as you were suggesting. And the way thyroid hormone acts in every tissue, not just the brain, but in the heart and muscles and every other structure, is by binding to what we call receptors in the cells in those tissues. So there's special receptors that bind thyroid hormone in the nucleus of the cell. And for example, in the brain, there are certain areas of the brain that are responsive to thyroid hormone. And if there's too much, then those cells are triggered to fire, and that can cause symptoms of anxiety and nervousness. trouble sleeping. And as you were suggesting, if there's too little, there are certain regions of the brain that are not functioning properly in that situation, and that can lead to low mood and even frank depression sometimes.
Dr. Cooper, how would somebody know that they had a thyroid gland that was not functioning optimally? What sorts of symptoms are the tip-off?
Well, that's a great question. And the problem is that the symptoms of thyroid disease are so nonspecific that many normal, healthy people can have the same symptoms as a person who had a thyroid problem might. So, for example, the cardinal symptoms of an underactive thyroid or thyroid hormone deficiency might be feeling sluggish and tired. It might be constipation, dry hair, dry skin, trouble losing weight. But many normal people have some of those symptoms too. On the other hand, as I was saying before, having an overactive thyroid might cause nervousness and jitteriness, palpitations, heat sensitivity, trouble sleeping at night. And again, many of these symptoms are common in normal, healthy people. So the bottom line is that if a person has any of these symptoms, it's impossible to know whether it's just another problem or maybe they're just having a lot of stress at work or whether it's their thyroid. So the threshold for checking somebody's thyroid should be very low. And if a person goes to their doctor or healthcare provider and says, I'm tired or I'm hot or I'm cold or I'm nervous or I'm constipated, their thyroid should be checked. Now, it may turn out not to be a thyroid problem, but that's one of the first things that should be checked.
How does a doctor check the thyroid?
Well, the first thing is they can examine the thyroid on a physical exam. So the thyroid is one of the only glands in your body that you can actually feel. The thyroid is located in the front of the neck, at the base of the neck near where the collarbone meets your breastbone. And if the thyroid is enlarged, it's often easy to feel. The doctor can also tell whether there are lumps or nodules in the thyroid. And certainly if the physical exam suggests that the thyroid is enlarged or, in any way not feeling the way the normal thyroid does, which is sort of soft and nondescript, that would be a clue that there's a thyroid problem going on. Also, many thyroid problems are inherited. And so it's really important for a doctor and for a patient to know their family history. Often we have patients who not only do they have a thyroid problem, but their sister and their brother and their mother and their grandmother and their cousin all have thyroid problems. So that's a very typical thing that we see. And so it's important for a patient to know their family history as well. But those clues, a family history, a physical exam, would then lead a doctor to suspect the thyroid, although, as I suggested, the thyroid should be checked anyway. But then there are certain blood tests that can be done very easily to tell whether a person's thyroid is working properly or not.
We'll dig a little deeper shortly into those blood tests and what they reveal. But first, it seems like there are a lot of things can go wrong with the thyroid. So we've heard about hypothyroidism, a sluggish thyroid gland, if you like. We've heard about hyperthyroidism, too active. We'd like to get a little more details about those. But then there are things that we've heard about, such as Hashimoto's disease. What is that? Graves' disease. What is that? And what causes it? So can you give us some sense of the most common thyroid conditions, what goes wrong?
Sure. If a person were to just diagram a list and a way of thinking about thyroid disease in general, 80% of all thyroid problems are autoimmune. So what does autoimmune mean? The word auto means self, and immune, obviously, that's the immune system. And in autoimmune conditions, the immune system turns on the person's own self and can attack a part of their body. And Hashimoto's thyroiditis is one of those autoimmune conditions, extremely common. Maybe 10 or 15% of all people have Hashimoto's thyroiditis. And this is an autoimmune condition where the immune system, I don't want to use the word attacks necessarily, but can infiltrate the thyroid and cause the thyroid to become inflamed and damaged and scarred and ultimately lead to the person developing an underactive thyroid. Graves' disease is also an autoimmune thyroid disease. So Hashimoto's thyroiditis and Graves' disease are the yin and yang of autoimmune thyroid disease. Hypothyroidism caused by Hashimoto's and hyperthyroidism caused by Graves' disease. And Graves' disease, named after Dr. Robert Graves, who was an Irish physician about 200 years ago, it's not a grave disease, is kind of the opposite of Hashimoto's. So the way the thyroid works is, like all the glands, to be controlled by your pituitary gland. And in the case of the thyroid, the pituitary secretes a hormone into your bloodstream that then goes to the thyroid and stimulates your thyroid to function, to make thyroid hormone, to release thyroid hormone into your blood. And this hormone is called thyroid stimulating hormone, or TSH. And like all the structures in your body that respond to hormones, there are receptors on the surface of the thyroid cell that respond to TSH. So when the pituitary secretes TSH, it binds to the receptors in the cells in the thyroid and triggers the thyroid to synthesize and then to release thyroid hormone into your blood. And in an incredibly eerie and strange way that no one can really understand, in Graves' disease, the immune system develops antibodies to the same receptor that TSH binds to and actually mimics the effects of TSH, which then stimulates the thyroid to make too much thyroid hormone. So here we have an autoimmune disease where the immune system is actually stimulating the target organ, in this case the thyroid, to make more thyroid hormone and to function even better than normal. And it's almost unique in all the autoimmune diseases that we know about, because in virtually every other case, the autoimmune disease destroys a part of the body. So in rheumatoid arthritis, the joints are destroyed. In ulcerative colitis, the colon is inflamed. But in Graves' disease, the thyroid works better than normal. So the thyroid grows and then starts to secrete too much thyroid hormone. So those two diseases, Hashimoto's causing hypothyroidism and Graves' disease causing hyperthyroidism, accounts for 80% of all thyroid disease. Now, Hashimoto's is much more common than Graves' disease, maybe 10 times as common in the general population. Now, the other 20%, there are people who have lumps and nodules in their thyroid. People can develop, as you know, thyroid cancer. There are inflammations of the thyroid called thyroiditis, not Hashimoto's, but different kinds of thyroiditis where there's inflammation, and that accounts for about 20%. Those are non-autoimmune causes.
You're listening to Dr. David Cooper, director of the Thyroid Clinic at the Johns Hopkins University School of Medicine. He's professor of medicine and radiology in the Division of Endocrinology, Diabetes, and Metabolism.
80%. Wow, that's a lot of people with autoimmune disease and thyroid problems.
That's right.
After the break, we'll find out why levothyroxine is the #1 drug in the country.
Why do so many people have sluggish thyroid glands?
Did our ancestors also have thyroid problems?
We'll talk about the blood tests used to diagnose thyroid difficulties.
And we'll also learn about the usual treatments for abnormal thyroid function.
You're listening to The People's Pharmacy with Joe and Terry Graydon.
The People's Pharmacy podcast is sponsored in part by Kaya Biotics. KAYA Biotics offers the first probiotics which are both certified organic and hypoallergenic.
All probiotics are produced in Germany under laboratory conditions with high-quality ingredients and under strict regulatory oversight.
The 3 available formulas are created for very specific purposes, such as strengthening the immune system, fighting yeast infections, and helping with weight loss.
To learn more about Kaya Biotics probiotics and the important topic of gut health, you can visit their website, KayaBiotics.com. That's KAYA Biotics.com. Use the discount code PEOPLE for $10 off your first purchase. Welcome back to the People's Pharmacy. I'm Terry Graydon.
And I'm Joe Graydon. If you would like to purchase a CD of this show, you can call 800-732-2334. Today's show is 1093. 800-732-162. That number again, 800-732-2334, or you can visit our website. It's peoplespharmacy.com. You can also download the free podcast from iTunes.
The People's Pharmacy is brought to you in part by Verizana, an analytical laboratory providing home health tests for hormones, gut health, and the microbiome. Online at verisana.com.
It's estimated that as many as 12% of Americans will develop a thyroid problem sometime during their lives. Could you be one of them? What should you know about the diagnosis and treatment of thyroid disorders?
Our guest is Dr. David Cooper, director of the Thyroid Clinic at the Johns Hopkins University School of Medicine. He's professor of medicine and radiology in the Division of Endocrinology, Diabetes, and Metabolism.
Dr. Cooper, the last time I checked, it seemed to me that the number one most prescribed drug in America today was levothyroxine, also known under the brand name Thyroid. And that's amazing. I mean, that means that the number one condition being treated by physicians is hypothyroidism. Did our ancestors all suffer from hypothyroidism the way we are? Is there any idea what's causing this huge number of people to have sluggish thyroid glands?
That's a great question, and I wish I could tell you the answer. You're right. Levothyroxine is the number one prescribed drug in this country. There were over 100 million prescriptions written within the last couple of years. And why hypothyroidism seems to be increasing in its frequency, I don't think anybody knows. But you're right, it is. One factor that may be playing into this that has been looked at from an epidemiologic point of view is iodine. And it seems that an excess of iodine in the diet actually can cause hypothyroidism, especially in people that have a tendency, because of their familial background, to have autoimmune thyroid disease. So part of this may be related to iodine intake.
Speaking of iodine, we, of course, are exposed to it through our diet, partially, especially seafood, and partially through iodized salt. But there's another way people are sometimes exposed to not just a little bit, but a humongous dose of iodine, and that's if they have to have a scan, an X-ray, an MRI with contrast. Quite frequently, that contrast media is iodine, and we've heard that there are cases where it can trigger hyperthyroidism, too much thyroid, as you pointed out, or even sometimes too little. How common is it, and what happens when that occurs?
Iodine and the thyroid are one of the most mysterious partners that I know about in all of medicine. Why iodine? Iodine is an element, and all animals have a thyroid. Fish have a thyroid, reptiles, mammals. And the thyroid hormone that the thyroid gland makes in all of these creatures is made out of iodine. Iodine comes from the sea, and it then enters the atmosphere and then rains down on the land, and then iodine is taken up by crops and animals who eat the crops, and that's how we get iodine into our diet. And you're right, there is iodine in many of the foods we eat. One source, for example, is from iodine-containing disinfectants that are used to clean cows' udders off. So the iodine gets into dairy supply, for example. But there's a love-hate relationship between iodine and the thyroid. And if you have too little, the thyroid can't make enough thyroid hormone, so that causes hypothyroidism. And if you have too much iodine, that also can cause thyroid disorders and thyroid malfunction. And in the case of these massive amounts of iodine that are used for radiologic procedures, in some people who have an underlying thyroid problem, not just a normal average person, but in some person who has a thyroid problem, who might not even have been diagnosed with that problem, but has an underlying thyroid problem that is so minimal that doesn't even cause symptoms, a lot of iodine can cause trouble. In certain cases, people with mild autoimmune Hashimoto's thyroiditis-like disease, which isn't even bad enough to cause their thyroid to not work, for reasons that are still not clear, when they're exposed to massive amounts of iodine, it can cause the thyroid to shut down and not make enough thyroid hormone. And that can cause transient or probably not permanent hypothyroidism, but at least for months it can cause hypothyroidism. And also people who have nodules in their thyroid. Nodules are just lumps that are benign and not doing anything bad. But if the thyroid is exposed to a huge amount of iodine like you get in a contrast study, for some reason, again, this is not well understood, they can be triggered into developing hyperthyroidism, where these nodules start to make too much thyroid hormone. So you asked how frequent this is. I don't think we know how commonly this occurs in people who get radiologic studies, but it certainly can happen. And so somebody might ask, well, gee, if I'm having a CAT scan with contrast, should my thyroid be checked? And some people actually advocate checking the thyroid before they have the study, or perhaps checking their thyroid, let's say a month after they have the study, just to be sure that the thyroid is continuing to function normally.
That seems like it might be sensible, especially if someone notices a change in the way they feel.
Especially if they have a family history of thyroid disease, even though they personally haven't been diagnosed.
Dr. Cooper, we talked about the fact that you use blood tests to help diagnose thyroid disease, and I'm hoping that you will explain something about those blood tests, and in particular, some of the controversy we've encountered in the last decade or so.
Sure. As an endocrinologist, we rely heavily on the laboratory to help us make a diagnosis, because the things that we care about, that is, hormones, are just chemicals that circulate in the blood. And fortunately, over the last couple of decades, the methods for measuring these hormones have become extremely sensitive and extremely precise. So we can tell with a great deal of confidence whether someone actually has a problem with their thyroid or not. And the main blood tests that we rely on are measuring the thyroid hormones, of course. So there's a hormone called T4, or thyroxine, which has 4 iodine atoms attached to the molecule. That's why it's called T4. There's a hormone called T3, which has 3 iodine atoms and is actually made from T4. So your body removes an iodine from T4 to make T3. And then the other thing we measure often is the thyroid-stimulating hormone, that pituitary hormone that I told you about that stimulates the thyroid. And the way this works is that the pituitary monitors how the thyroid is functioning. And let's say a person develops Hashimoto's thyroiditis and the thyroid is inflamed and damaged and the level of thyroid hormone goes down. The pituitary senses that, and it senses that it needs to make the thyroid work harder. So it makes more TSH to try to get the thyroid to make more thyroid hormone. So a person that has an underactive thyroid will have a low level of T4 and T3, but the TSH from the pituitary, the thyroid-stimulating hormone, will be elevated. On the other hand, let's say a person develops Graves' disease and the level of T4 and T3, because the thyroid is making too much on its own, goes up. The pituitary senses that the levels are too high, and it says, I don't have to stimulate the thyroid so much because there's already plenty of thyroid hormone, so the TSH will be low. So the pituitary TSH secretion is a mirror to how your body is thinking about your thyroid hormone level, and it's extremely sensitive. So even if the thyroid hormone levels in the blood go up a little bit or down a little bit, even within the normal range, if it's not normal for you as an individual person, the TSH will be high or low. So if a person develops, let's say, a mildly underactive thyroid, and the T4 level goes just down a little bit, the TSH will be high, even if the T4 is still technically within the range of normal, because it's not normal for that individual person. So those are the cardinal blood tests that we do, measuring the T4 level and measuring the TSH. And then there are ancillary tests too. We can do tests to check if the person does have Hashimoto's thyroiditis. There are antibodies to the thyroid that we can measure in the blood. The antibodies to the TSH receptor that stimulate the thyroid in Graves' disease, we can measure those in the blood. So those are the cardinal blood tests that we do. And unfortunately, as I said, they're very, very accurate. But one thing that's happened recently that maybe you were kind of alluding to is substances in the blood that can interfere with the interpretation of these blood tests. And the main one that we're facing now is biotin. And as you know, biotin is a vitamin that many people are taking now as a supplement. It's supposed to be good for hair and nail growth. And biotin can interfere with virtually all the tests that we do to check your thyroid. Now, not every method is interfered with by biotin. So in a chemistry laboratory, there are different companies that make the reagents and equipment to do tests, and not all of them are interfered with by biotin, but many of them are. And there's no way a doctor knows which method is being used by which laboratory. So we now advise anybody who's having a thyroid exam with blood tests to stop taking biotin for at least 72 hours before they have any thyroid tests done.
Dr. Cooper, there is another controversy, and we hear from a lot of patients who say something along the lines of, my TSH was quote-unquote normal. And the doctor said my thyroid is functioning perfectly, but I feel, pardon this, like crap. I'm tired all the time. I gain weight. My skin is dry. My hair is brittle. I'm constipated. I've got every symptom in the book.
Some of this has to do with the cutoff for diagnosis. So the patient or person who may not be a patient yet may tell us, well, my TSH came in at 5.75 or 6 or 7, and the doctor says that until it's 10 or 20, it's not really hypothyroidism.
Well, there's two categories of people. One is people that feel like crap, as you said, but their tests are all normal. The TSH is normal. The T4 is normal. Everything's normal. They don't have a thyroid problem, even though the symptoms are reminiscent of some underactive thyroid, let's say, like I was saying. The symptoms you're discussing or describing are very common in just normal people who don't get enough sleep or don't get enough exercise or eat the wrong foods. And if their thyroid tests are in fact normal and their TSH is in the reference range, they don't have a thyroid problem. On the other hand, there are people who have a lot of symptoms and they do not have normal thyroid function tests, but maybe they're just slightly off and slightly outside the range of normal. Those people may have symptoms that are ascribed to their mild thyroid problem or not. It's hard to say. I will say, though, that in randomized controlled trials, when people with mildly elevated serum TSH levels, as you were describing, who have very mild hypothyroidism, are given levothyroxine or placebo, there was no difference between those two groups in terms of how they responded. So it's been hard to prove that when people have symptoms and they have a very mildly underactive thyroid, that those symptoms can be improved by taking medication.
So the treatment didn't make it.
It didn't help. And that's not to say that in an individual human being, giving treatment might not help. It might. Remember, these are studies, let's say there are 100 people in the study, and then on average, people didn't feel any different. But that's not to say that an individual person might not. And so in my view, if a person does have a mildly elevated TSH, let's say indicating mild hypothyroidism, then it's certainly reasonable to give that person a trial of thyroid hormone to normalize their thyroid hormone levels and normalize their TSH level and see how they feel. And some people do feel better. Some people don't. Some people feel better for a month or two, and then they just go back to feeling the way they did. So it's hard to predict, but I think everybody deserves a chance, at least of being treated and seeing if it improves things. But there's no evidence that people who have completely normal tests will feel any differently than people who take thyroid hormone versus placebo. So there's no evidence that treating a normal person will help them.
Let's talk about treatment for someone whose thyroid is not normal. And I think we want to talk about both treating hyperthyroidism as well as treating hypothyroidism. How do you treat someone who has too much thyroid hormone on board?
Well, as I was saying, the most common cause of too much thyroid hormone is Graves' disease. This is this autoimmune disease where the immune system is stimulating the thyroid through TSH receptor antibodies to overfunction and make too much thyroid hormone. And I'm embarrassed to tell you that the treatments we have for this are no different than the treatment your grandmother or great-grandmother would have had. So surgery is a treatment. Radioactive iodine is a treatment, which was introduced in the 1940s. And there are medicines that we can use to slow the thyroid down, also introduced in the 1940s. So there's nothing new to do about an overactive thyroid. Now, how does a patient decide which one of those treatments is best for him or her? And nowadays, it seems as though most patients opt for taking medication. There's a medicine called methimazole, and the brand name is Tapazole, that acts to interfere with how the thyroid utilizes iodine in the diet. And by interfering with that enzymatic process in the thyroid hormone levels will decline, and they will become normal within a few weeks or a month or two on methimazole. And since Graves' disease is an autoimmune disease, which tends to fluctuate and wax and wane, sometimes people, after a year or 18 months or 2 years of methimazole therapy, have what's called a remission, where the antibodies go away. And if you stop taking the methimazole, the disease does not come back. So that's called being in remission. A remission is defined as being normal for 1 year after stopping the medicine. On the other hand, some people never go into remission, and they are controlled while they take the medicine, but if they stop the medicine, they just become hyperthyroid again. So the medicine is a popular way of treating it. There are allergic reactions that some people have, but most people take this medicine without any difficulty. And now the trend seems to me, at least in my practice at Johns Hopkins, for people to take the medicine sort of indefinitely. And when it's controlled well and people are on a low dose of medicine, it works great. Some people have a bad experience with the medicine, or they have a side effect, or they just don't want to take it. And for them, a more definitive treatment is what would be required. And the two definitive treatments, unfortunately, destroy the person's thyroid. So they end up having an underactive thyroid. So radioactive iodine, it's simple to give. It's just a pill you take. It contains iodine that's been made radioactive, and the thyroid takes it up. It gives the thyroid radiation and destroys the thyroid. People are hesitant to do this often. A, they're afraid of radiation. B, it's known now that radioactive iodine can make eye problems worse. And as we didn't talk about this, but I think many of the listeners know that when people have Graves' disease, they can have bulging or prominent eyes. And radioactive iodine can make that worse. So many people just don't want to accept that as a treatment. But it does work, and sometimes we use that. In fact, I have had radioactive iodine for Graves' disease myself. And then the third treatment is surgery. This is, of course, the oldest treatment, and that works, but it requires an operation, and it's major surgery. So those are the three treatments that we have for Graves' disease.
You're listening to Dr. David Cooper, director of the Thyroid Clinic at the Johns Hopkins University School of Medicine. He's professor of medicine and radiology in the Division of Endocrinology, Diabetes, and Metabolism.
We need to take a short break. When we come back, we'll find out a bit more about how underactive thyroid glands are treated.
Do you need to take both T3 as well as T4?
When's the best time to take your levothyroxine?
Why is thyroid cancer being diagnosed more frequently?
We'll also discuss drugs that can interfere with thyroid function.
You're listening to The People's Pharmacy with Joe and Terry Graydon. This People's Pharmacy podcast is brought to you in part by Verizana.com.
Verizana Lab offers home health tests that allow you to monitor your hormones and health conditions. You can take control of the quantitative assessment of your health and learn about male and female hormone balance, the stress hormone cortisol, leaky gut, gluten intolerance, or your gut microbiome.
Take a more active role in tracking your health and take 20% off your first order of a mail-in testing opportunity with the discount code PEOPLE. That's PEOPLE, all uppercase. To learn more, go to Verizana.com. That's Verisana.com.
Welcome back to the People's Pharmacy. I'm Joe Graydon.
And I'm Terry Graydon. To purchase a CD of today's show or any People's Pharmacy broadcast, you can call 800-732-2334. Today's show is number 1162. That number again, 800-732-2334. You can also place your order online at peoplespharmacy.com or download the free podcast from iTunes or from our web store. We invite you to consider writing a review.
The People's Pharmacy is brought to you in part by Kaya Biotics, probiotic products made in Germany from certified organic ingredients. That's Kaya Biotics.com.
What's the best treatment for an underactive thyroid? You might be surprised to learn that there's some controversy about exactly how this common problem should be managed.
Our guest is Dr. David Cooper, director of the Thyroid Clinic and professor of medicine and radiology in the Division of Endocrinology, Diabetes, and Metabolism at the Johns Hopkins University School of Medicine.
Dr. Cooper, we've been talking about hyperthyroidism. I wonder if you can tell us how hypothyroidism is usually treated and perhaps what some of the considerations might be.
Well, hypothyroidism is a deficiency of thyroid hormone, so you'd think it would be easy just to give the person back the thyroid hormone that their body can't make anymore. And in fact, when hypothyroidism was actually recognized as a medical condition, the original treatment for hypothyroidism was to take the ground-up thyroid glands of sheep and saute it and feed it to people as food. And then chemists became adept at making thyroid hormone from desiccated thyroid glands of pigs and cows and sheep. So people took thyroid hormone as what was called desiccated thyroid, which was just dried up thyroid glands from animals. But then in the 1960s and 70s, scientists became adept at synthesizing thyroid hormone in a laboratory. It's a very small, easy-to-make molecule. So now most people who take thyroid hormone to treat thyroid deficiency take a pill called levothyroxine, which is T4, and the same stuff identical to what your own thyroid gland makes.
Now, let me interrupt you right there, if I may, Dr. Cooper, because what you said just a moment ago was, well, we need to give back what your body's not making adequately.
Mm-hmm. Right.
And you said a little earlier that the body makes both T4 and T3, one with 4 iodines, one with 3 iodines. And I think the way that happens is the body actually cleaves away one of those iodines. So you go from T4 to T3 through an enzymatic process. But what you're talking about, this levothyroxine, the Synthroid, standing for synthetic thyroid, I suspect, it's just T4. That's what you said a moment ago. That's not what the body makes. And it's our understanding that T4 is, quote unquote, inactive, that the body has to activate it to this T3. So all those years when people were getting the so-called natural thyroid, before the synthetic came along, they were getting both T4 and T3 from those animal extracts. But now it's primarily just T4. And we've heard from an awful lot of people, and a fair number of health professionals as well, that some people, either because of genes or some other factors, just don't convert T4 to T3 very efficiently, whether it's 5% or 10% or whatever the number is. So help us understand why modern medicine, for the most part, hasn't given back both the T4 and the T3.
Somehow I knew you were going to ask me this question, so I'm glad you did. And it's not easy to answer, but let me see if I can try. Yes, the body makes T4 and T3, and the vast proportion of the T3 that arises in your body every day comes from the conversion of T4 in peripheral tissues like the liver and the kidney and the muscle. Only a small amount of T3 is actually made by the thyroid gland. And yes, you are right that T3 is the active thyroid hormone, not T4. So when we were talking before about thyroid hormone getting into cells and in regulating the metabolism, it's really T3 that does all of that stuff. So it is important for a person to have a normal amount of T3 as well as T4 because that's where the T3 comes from. So let's just take the simplest scenario where a person has had their thyroid taken out surgically. Let's say it's a patient who has thyroid cancer, and now they have had their thyroid removed. So they have no thyroid hormone of their own at all. And if you put that person on levothyroxine alone, sometimes the T3 will be lower than it was before they had their surgery. So there are studies where they have measured thyroid hormone levels, T4, T3, TSH, before the surgery, and then they measure it after the surgery while the person is taking levothyroxine. And almost inevitably, the T4 levels actually are slightly higher than they used to be, and the T3 levels are slightly lower than they used to be in that person. And that's probably because you're missing the 20% of the T3 that came from the thyroid gland. And also maybe the conversion of T4 to T3 may be slightly lower than it ought to be, but it's probably more just you're missing that 20%. So if a person has an underactive thyroid, the thyroid isn't making enough T3 anyway. And so the T4 may or may not replace all the T3 that used to be made by their thyroid. Now, it is true that desiccated thyroid or thyroid medicine that came from animal thyroids does have T4 and T3, but it's the wrong proportions. And so animal thyroids don't have the same amount of T4 and T3 as the human thyroid. And so often when people took desiccated thyroid, and the typical one is called Armour thyroid. Armour is a meatpacking company. Armour thyroid had too much T3 in it. So people who took this sometimes would develop hyperthyroidism, sort of, made by the doctor or the patient because they were taking too much. So there are ways of giving T4 and T3 back to people. And the reason it hasn't caught on is because there is no long-acting T3 preparation that we can give patients. So the T3 pills that we have that we can use to replace the T3 that we might want to replace has a very short duration of action. And so it gets into the body and then it just disappears really quickly. So it has to be taken twice a day. So it becomes just a more complicated medical regimen. But I agree with you that there are people who are completely normal, healthy people who undergo thyroid surgery, let's say. They get put on levothyroxine alone, and 6 or 8 weeks later, they're not feeling well anymore. Now, they just had surgery, it's true, but they just have a lot of symptoms. As you were saying, they're tired and they don't think clearly and some other symptoms. And if you check the T3 level in those people, often it is on the low side or even below normal. So doctors, I think, nowadays are much more willing to consider that this is actually a problem and that giving a person a levothyroxine pill is not giving them a thyroid transplant the way we used to think it was. So I agree with what you're saying, and I think each patient needs to be treated as an individual, and doctors need to be more open-minded about this.
It's good to hear that the thinking is evolving. We have heard from some people who take T3 in a compounded form to eliminate the need to take it twice a day. So it's a presumably slow release. Have you any evidence that that works well or does not work well?
Well, I think that I'd be just suspect. I know that this is a popular thing for people to do, but I don't trust compounding pharmacies. So maybe that's just my bias. I've seen patients who are getting medicine from pharmacies that have compounded their medicine and the levels are too high or too low. They're just not, I don't think it's necessarily accurate.
Dr. Cooper, one other thing. People who take levothyroxine, let's say they're taking Synthroid or something similar to Synthroid, there are some restrictions that they're given when, if the doctor is being very thorough, he or she may say, now, you have to take this first thing in the morning as soon as you get up, and then you have to go for at least an hour or at least half an hour and preferably an hour before you have any coffee or any breakfast or anything like that. A lot of people find that regimen pretty challenging. What can they do about that?
Yes, I agree. And I have patients who even wake themselves up at 4 o'clock in the morning just to take their pill, and then they go back to sleep again.
Yeah, we've heard from those people, too. Yeah.
So I think that it is true that it would be better to take the medicine on an empty stomach. And it is better to wait at least 30 minutes before people eat. But I think doctors can get carried away and say, oh, no, you can't eat for an hour, which I don't think is true. Also, what I think can be done to help people would be to take it at bedtime. Usually at bedtime you will have eaten many hours before. You're not going to eat afterwards. And that's just a quick, easy way of just circumventing this whole issue.
Dr. Cooper, we've heard about some newer liquid or soft gel preparations of thyroid hormone. What's the story on them, and is that something that a patient can request as an alternative?
So the product you're talking about is called Thyroid, and this is made by a company in Europe. And actually in Europe, there's two different kinds, I think. One is actually a true liquid where the thyroid hormone is dissolved in alcohol. And then there's the Thyroid that's available here in this country where it's a gel cap and it's dissolved in glycerin, I think. And there are people who seem to be sensitive to some of the constituents of the tablet, not the thyroid hormone per se, but the dye or the fillers. And they request, because of a perceived intolerance, Thyroid, because Thyroid has nothing in it. There's no colorant, there's no filler. It's just a capsule that has gelatin in the thyroid medicine. So some people swear by it. Now, it's very expensive, and often insurance will not pay for it. But if there are patients out there who are having issues that they perceive to be related to their thyroid medicine, it would be something to talk to their doctor about.
Dr. Cooper, there seems to have been a significant increase in thyroid cancer over the last several years. Can you tell us a bit about thyroid cancer? Do we know why it seems to be increasing and what is done about it?
I'm glad you asked that question. This is a worldwide phenomenon, and it's been called an epidemic. 10 or 15 years ago, thyroid cancer wasn't even on the radar screen. If you look at the NIH statistics or the National Cancer Institute statistics on thyroid cancer, or on cancer in general, thyroid cancer wasn't one of the top 15 cancers. Now, with the last iteration of their report, which was last year, and they do a report every year talking about the frequency of cancer, thyroid cancer was the 5th most common kind of cancer in women. So it rose from nothing to being 5th most common. And this is true of virtually every developed country in the world. So what is happening here? Is there something in our food or air or being exposed to some environmental toxin? Most people think that the explanation for this is just the increased exposure of people to medical imaging and the sort of coincidental finding of a thyroid nodule on some kind of imaging that they had for some other purpose. So a CAT scan of their chest can show the thyroid. People can have ultrasound of their carotid artery to look to see if they have atherosclerosis, and that can show the thyroid. People are having just more exams in general by doctors, and that finds a thyroid nodule. In some countries like Korea, people had thyroid ultrasounds just done routinely as part of the annual health exam. And so this led to the discovery of thyroid cancers in ever-increasing amounts every single year, most of which were small and probably not very harmful. So thyroid cancer, fortunately, is a indolent kind of cancer that rarely spreads and rarely kills people. And so finding a small thyroid cancer is not necessarily advantageous to people, just like finding a small prostate cancer, as you, I'm sure, know, is not necessarily going to help the person by finding it and treating it. But anyway, that is the source of most of the increase in thyroid cancer. And fortunately, even when people are found to have thyroid cancer, for the most part, just by removing the thyroid, or sometimes just half the thyroid where the cancer is, cures the person almost always, especially if it's a young, otherwise healthy person and the cancer is a small one, which they usually are.
Dr. Cooper, so what should people be doing to enhance thyroid function or just keep their thyroid as healthy as possible?
I think the diet is very important, especially to be sure that people have enough iodine in their diet. Iodine is essential for the thyroid to function normally, and so I think that people should be using iodized salt because it's possible that they're not getting enough iodine otherwise. This is especially true for women who are pregnant and breastfeeding. There's a lot of discussion about how soy can affect the thyroid. If people do have a mildly underactive thyroid, taking a large amount of soy, let's say in tofu, could theoretically make the thyroid function less well. So maybe people that have mild thyroid disease should avoid large amounts of soy. Also, soy can interfere with thyroid hormone absorption from the pills that we take for thyroid deficiency. We know that stress can trigger Graves' disease in people that have a genetic tendency toward having Graves' disease. And so how people manage stress and handle stress, I think, is impossible to know in terms of how much of an effect that will have on their thyroid. We have people who have Graves' disease, and we ask them, have you been under stress? And they inevitably say yes, but whether that stress triggered Graves' disease or not, it's hard to say. And also, when people are diagnosed with Graves' disease, we also tell them to try to avoid stressful situations and to take it easy and, not work too hard and not do anything that's very stressful, because we do think that their thyroid function will improve if they live a less stressful life, at least for the first few months after they're diagnosed.
Of course, that could be quite a challenge.
Sure, especially since they feel hyperthyroid, so they feel stressed out anyway.
And if they get certain medications, one is a heart drug called amiodarone and another lithium for psychiatric issues, those can impact the thyroid, can't they?
Yes, so people who take drugs, especially those two that you mentioned, need to have their thyroid levels monitored every 3 to 6 months, as long as they're taking those medications.
Dr. David Cooper, thank you very much for talking with us on the People's Pharmacy today.
It was my pleasure. Thank you.
You've been listening to Dr. David Cooper, director of the Thyroid Clinic at the Johns Hopkins University School of Medicine. He's professor of medicine and radiology in the Division of Endocrinology, Diabetes, and Metabolism.
Lynn Siegel produced today's show. Al Wodarski is our engineer, and Dave Graydon edits our interviews.
The People's Pharmacy is produced at the studios of North Carolina Public Radio, WUNC.
The People's Pharmacy theme music is by B.J. Liederman.
The People's Pharmacy is brought to you in part by Verizana, an analytical laboratory providing home health tests for hormones, gut health, and the microbiome. Online at verisana.com.
To buy a CD of today's show or any other People's Pharmacy broadcast, you can call 800-732-2334. Today's show is 1162. That number again, 800-732-2334, online at peoplespharmacy.com.
And when you visit our site, you can share your thoughts about today's show. Have you had experience with a malfunctioning thyroid gland? How was it diagnosed? How did the treatment go? You'll also find our free e-guide to thyroid hormones.
What are the symptoms of hypothyroid, Terry?
Well, there's an awful lot of them. Fatigue, weakness, constipation, dry skin, hair loss, irregular menstrual periods, and here's a strange one, you lose the outer third of the eyebrow.
And of course, there's depression and high cholesterol and cold sensitivity and a reduced heart rate and trouble controlling your weight.
At peoplespharmacy.com, you can sign up for our free online newsletter or subscribe to the free podcast of the show. You'll never miss another episode, and you can share it with a friend.
And when you sign up for the newsletter, you'll get our free e-guide to favorite home remedies. In Durham, North Carolina, I'm Joe Graydon.
I'm Terry Graydon. Thanks so much for listening. Please join us again next week.
We hope you enjoyed this podcast. If so, please consider taking a minute to write a review on iTunes. And thanks for listening to The People's Pharmacy.